Change Healthcare is a key catalyst of a value-based healthcare system, working alongside our customers and partners to accelerate the journey toward improved lives and healthier communities.
You become a doctor to take care of patients. You become a doctor to serve humanity. Ambient intelligence allows for the patient and doctor to be a patient and a doctor. That like it used to be.
MedEnt helps you focus on what matters most. MedEnt, the all-in-one solution.
Hi, I'm Tony Stadehar, the president of Jackson Physician Search, your executive partner and trusted physician recruitment firm. Come visit our virtual booth to discuss your physician needs, but until then, I hope you enjoy this great event.
We've documented over $8 million in saving. What we're really thrilled about, though, is just the individual member testimonials. Once we get it set up and running, it really takes on a life of its own, sometimes with suppliers, and we make a real difference in the financial viability of their practice.
Did you know that Scrub-In Uniforms is great for groups? With easy-to-set-up custom ordering portals and convenient payment methods, we take the stress out of buying uniforms for your team.
Hey, this is James from Relation, the class category leader for patient outreach in 2020. If you've been doing more with less this year and introducing new workflows to keep patients and staff safe while continuing care, it's time to connect. Stop by the Relation booth and watch our presentations here at the conference.
Eagle, go. ECOM, 15 seconds. 3, 2.
Audi e-tron, the next frontier of electric.
CareCredit is proud to sponsor the Leadership Pathway for the Medical Practice Excellence Conference. Recently, more than ever before, we have seen firsthand that smart, solution-driven, passionate, and compassionate leadership is vital to the business of healthcare. CareCredit is dedicated to your leadership potential, and we are thrilled to support the commitment to growth and continued pursuit of knowledge within this educational pathway. Now, onto the session.
Hello everyone, my name is Chris Harrop, Senior Editorial Manager at MGMA. Welcome to today's session, the ROI on Optimizing Advanced Practice Providers. We have a few reminders before we begin. You can claim ACMPE, ACHE, CME, and CEU credit. Attendees of the live session also can claim AAPC, CPE, and CNE credit. Claim continuing education credits starting next week using the MGMA CEU portal. For AAPC credit, the code will be emailed to you. Submit your questions, resources, and comments using the chat area. Slides and resources can be found in the lower left section of the previous session page. And with that, the education for this session will now begin. In today's session, Amy Noker, Principal for the AAP Workforce Practice at Sullivan Cotter, and Zachary Hartzell, Principal of the APP Workforce Practice at Sullivan Cotter, we'll explore strategies for optimizing APPs and redesigning care models to help promote high-performing provider teams that yield a substantial return on investment. Amy and Zach, I know you've got a lot of great information to share, so I'll turn it over to you.
Good afternoon, and thank you for joining us today. Welcome to our talk, the ROI on Optimizing Advanced Practice Providers. We'll be focused today on this key strategy, one that many organizations consider an imperative to future success. In light of ongoing financial pressures as a result of COVID-19, as well as changing payment models, organizations are realizing it is essential to ensure care models are intentionally designed and every member of the care team is truly optimized. My name is Amy Noker. I'm a principal at Sullivan Cotter. I'm joined today by Zachary Hartzell, also a principal at Sullivan Cotter in the APP workforce. Sullivan Cotter partners with healthcare organizations across the country to help drive performance, improve outcomes through the development and implementation of integrated workforce strategies. Let's get started. As reference, when we say APPs in this presentation, we mean advanced practice providers. So advanced practice registered nurses, NPs, CRNAs, CNMs, and some clinical nurse specialists, as well as physician assistants. Today's presentation will cover these three learning objectives. We'll be looking at national trends related to APP utilization. We will consider how organizations develop frameworks to support APP integration and how this can in turn support organizations' strategic goals. And finally, we will look at how APPs can help support objectives as organizations transition to a value-based environment. This is our agenda. First, we will touch on the changing healthcare environment and the impact of COVID-19. Secondly, we will share our experience and expertise in care team optimization. And thirdly, in support of care team optimization, we will cover compensation planning. Finally, we will summarize some key points related to supporting a successful APP structure, including APP leadership and engagement. All right, here we go. Obviously, it's difficult these days to talk about healthcare without acknowledging COVID-19 and in consideration of its impact of the future, on the future. In our recently published article in HFM magazine, Zach wrote, as hospitals and health systems plan for post-COVID-19 recovery, the focus will be on optimizing care delivery and lowering expenses while increasing revenues to help ensure financial sustainability. Further, enhancing the use of existing resources will be a critical part of organizations' plan for post-COVID-19 recovery. And now we've watched this really playing out. Rather than simply returning to business as usual, organizations will need to make financial and operational improvements to adapt to the changed environment, including taking steps to optimize care teams. So as part of this effort, we're seeing leaders focus on the roles of APPs. And really, even before the pandemic hit, many hospitals and health systems were beginning to prioritize the optimization and engagement of their APPs in order to enhance performance of their clinical workforce. One important consideration to start, despite the significant growth in the APP workforce during the last decade, healthcare organizations all too often have not seen reciprocal gains in revenue and access. So without the corresponding increases in patient volumes and revenue, operating margins really can't sustain any unsupported cost. And the disconnect between APP staffing and performance has several primary causes that we observe, including inefficient care delivery, underutilization of APPs, redundancy of tasks or duplication of efforts between the physicians and APPs, as well as the misalignment of physician and APP compensation, which really in the past several years has become a key component to proper optimization of care teams. So as we look at the market, we see the potential for transformational change with COVID-19 really as the primary accelerant. So as if adapting to a global pandemic was not challenging enough, the fallout really showed the economic stability, or really we should say the economic instability of the current healthcare delivery model. So now organizations are weighing whether they can afford to return to the old model, or if this time of disruption is really a chance to reset using a different formula. So we've watched the demand for APPs closely year after year, and for the last 10 years or so, the story has maintained APP occupations are some of the fastest growing. We're looking at nearly a 40% increase in PAs and NPs in the 10-year period from 2016 to 2026. This is despite projections of a shortage of both physicians and APPs nationally by 2025. And while shortages are an issue, there is a compounding problem with the distribution of physicians. So nearly 3/4 of the states are expected to have primary care physician shortages by 2025, As well, as you all know, their concern continues to grow for new and existing patients, wait times, sometimes weeks, sometimes months in certain specialties. And we know from our work with clients across the country that many organizations are planning and accounting for these upcoming challenges with their provider workforces. So before the pandemic hit, the industry was really focused on investing in information systems to support care delivery and strategic goals, but was also challenged with changes in reimbursement and more competition in the market, which was really narrowing margins. So as COVID hit, we really watched this very rapid sliding decline of productivity, putting a significant financial strain on the industry. And really quickly, as the pandemic started, organizations had to shift, assess, and then change how they do things. So for instance, consider the rise of telemedicine. So there's been now a significant investment in telemedicine and both capabilities and infrastructure. And that has had, and surely will continue to have, a really profound impact on how care is delivered. So as we look to 2021, we know many healthcare organizations are right-sizing their cost structures and looking at longer-term changes to their operating model, both in organizational design and structure. So last spring, Sullivan Cotter deployed 2 nationwide surveys, and we've pulled here some of the key highlights related to APPs. One really striking finding from the research was around the redeployment of APPs. So common specialties considered frontline providers in COVID-19 services are critical care APPs, CRNAs, intubation and line team members, emergency medicine, hospitalists, infectious disease specialists. So the APP workforce, as you know, has some flexibility to move across practices, but what has been observed and what's really been key is the quick development and implementation of training programs and the necessary credentialing to allow APPs to provide and bill for medical level of care services in their new areas. So for APPs working in frontline specialties, premium compensation usage remained relatively small at 14% of organizations having implemented premiums. These are most commonly applied to work effort outside of standard expectations. We do expect organizations to be fairly cautious in their approach to future incentive design. As APP compensation plans typically have little at-risk dollars, and as a workforce in high demand, organizations will have to carefully weigh recruitment and retention drivers with changes to compensation plan design. So there are a lot of pieces that go into an organization's strategic approach to their APP workforce, and this graphic shows some of the main components. Given the trends we see with clients, I'll highlight the most pressing issues. Structured onboarding programs, and increasingly fellowships, competency assessment, workforce planning, assessment of hiring APPs, both new and replacement positions, leadership structures, and of course, compensation. During the past 5 years, the APP market data has moved rather quickly. And when you combine that with not accurately anticipating both the growth of the APP workforce nor the market movement, many organizations are finding themselves with recruitment and retention issues specific to APPs. So I guess I'll just undoubtedly say keeping pace with your APP compensation program is really important, and Zach is going to talk through that in some more detail later in the webinar. So let's take a look at care team optimization. Some of the national trends around this that we're seeing as organizations are considering optimizing their care teams to support recovery efforts from COVID-19. So things like improving access, quality or patient care measures, and even reducing costs of care. Organizations are looking at care team optimization and in particular APP optimization in order to meet some of these needs. So this model is a sample diagram of the primary care team as defined by HRQ in their patient-centered team-based primary care models. So while care teams in the surgical, medical, or hospital-based specialties may have some different roles and team members, this model serves to remind us and to kind of help think through all the roles of the care team as they're interconnected. So while we often think about the providers on the care team, so the physicians and the APPs, and think about having them make change, it's often changing other roles as well to help support their work that can have a big impact on capacity. To give you a picture of how we see this playing out, we tend to think about care teams in one of three stages: underutilized, transitioning, or optimized. So as you look at this, think of these classifications as a gradient as opposed to specific silos, as organizations will often move through elements of these, some faster than others. So in organizations with underutilized care teams, so that dark gray column, we tend to see very little strategy as to the makeup or planning of the APP workforce. We see that team members are really focused on accomplishing specific tasks or individual goals. In transitioning organizations, we do see some examples of care team strategy, although it may be inconsistent. There may be some areas where there are role-specific workflows, but they're not necessarily tied to specific goals. So in this model, in this transitioning model, APPs are often identified and recognized, but we tend to find that their roles are often underutilized. So by contrast, along the right-hand side, in optimized organizations, or I should say organizations with optimized APPs, they're really functioning as true care teams. So there's likely been a well-developed intentional strategy that is aligned to organizational strategy. So importantly, these teams we see as focused on patient outcomes with activities and responsibilities aligned to that, so such as quality, satisfaction, and access. Interestingly, decisions in these models are typically data-driven, and it's really about getting patients, seeing that they get the right care at the right time from the right provider. So we do, of course, recognize that there can be barriers to optimization for the whole care team, and this slide really depicts a set of specific barriers that are really focused on APPs. Some of this may ring true for all of you as you reflect on your organization. Impact can be felt from how senior physician leadership views APPs within the organization, how patients perceive seeing an APP versus seeing a physician, and how the organization is working on educating patients in that regard. There can be perceived or even real productivity competition between APPs and physicians. Hospital bylaws or system bylaws may be old compared to what is current state law practice. Affiliation arrangements and how they're structured, or how they work together between employed and other types of affiliations such as PSAs, and of course some perceived liability risk from physicians on the care teams. So things to keep in mind as you're thinking about your organization and how you may optimize care teams. In talking through this process, the importance of care team optimization, this slide is a nice illustration around financial impact. So along the top, we've listed different types of employees and their corresponding salaries, though I will note these are sample numbers. The third row shows capacity in minutes for each employee type, and the bottom row shows the equation capacity to dollar rate per minute. So what this shows, and I'll just be direct here, is that a PA can be an expensive scribe or office assistant. So this isn't to suggest nor to give judgment to the roles that different providers undertake or employees working above or below their scope of license, but this is to give your organization an opportunity to look closely at how APPs function in a supportive role, and determine what the price tag is for that to see if it's a good use of financial resources. So here we can look at an example of the impact of turnover, impact on financial resources. This is a client that had a higher than average external turnover rate for APPs at 16%. Survey data found and focus groups really confirmed the sense of disengagement of the APPs related to a few key areas, including lack of CME stipend, hard to achieve incentives that were based on RVU targets, and further lack of representation or support at the organization level. So the incentives were specifically or particularly troublesome, as many APPs were in roles that did not allow them to generate work RVUs, or were in inpatient practice where they received no work RVU credit. So the direct cost of this turnover, utilizing Sullivan Cotter research, was estimated at $2.8 million a year. And this does not even represent all of the indirect costs of turnover, which might include things like staff morale, decreased patient access. So in this case, the opportunity was really identified as a potential cost saving. Organizational leadership determined there was a readiness to reevaluate the incentive program and, in fact, to consider the development of an APP leader position. Let's take a look at this case study. It's based at an academic medical center where we worked with a client that was concerned about perceived underutilization of their APPs across several service lines. Interestingly, one of the issues identified early on was varying opinions on which specialties were utilizing APPs well and which were not. So there had not been a formal quantifiable assessment of the potential opportunity. Our approach consisted of both physician and APP perception surveys, interviews with department chairs, administrators, practicing APPs, as well as a productivity assessment. And as it turned out, according to that assessment, 58% of their APPs were identified as having an opportunity to improve revenue by bringing their productivity up to market benchmarks. So 58% were identified as having opportunity for additional revenue capture. And the range of the overall financial opportunity was between 7 million and 12 million. This would depend on the benchmarks and the performance levels utilized. So in addition, the surveys of the APPs and physicians identified both groups with some dissatisfaction with the current care model, with significant barriers to being able to practice at top of ability or license. So this included administrative tasks that they were asked to do on both sides, scheduling follow-ups, checking in patients, so on and so forth. So the assessment in this case identified a real quantifiable financial opportunity through better utilizing APPs. As well, the surveys really identified this readiness for change both by physicians and APPs. This scenario is based on an orthopedic group. The group was being challenged to increase their surgical volumes as well as improve overall team productivity. And initial assessment found their APP productivity well below the 25th percentile. So we frequently hear, and this won't be a surprise to any of you, that surgical specialties, it's difficult for APPs to increase their work RVUs because the majority of their work takes place within the global period. However, national data is showing that compared to this organization, there were APPs across the country being utilized differently. So the approach we took was to walk through their current state of their care model as identified by physicians and APPs. And what was uncovered was that physicians were seeing all of the new patients, most non-surgical follow-ups, most of the pre and post-ops, all of this while trying to maintain a full surgical schedule. So they were also doing inpatient discharges. So one has to ask, why was this happening? Really what we discovered was that there had never been intentionality around clarifying what their care model was and what everyone's role was. So through intentional discussion, it was decided that physicians would continue to see all new and second opinion patients. APPs would see many of the non-surgical patients for interventions until they were ready for surgery. APPs would see certain populations like ER follow-up or fracture clinics. And each day an APP would be designated to complete all discharges. So one other note here to ensure, well, one of the concerns was around patient perception. And so what this organization did was have surgeons introduce APPs to new patients and to their families on first visit. So that way there was a sort of a warm handoff to build trust in the team as a whole. So interestingly, allowing the APP to do more work independently showed an almost 200% increase in APP work RVUs over that first year. And the surgeons were also freed up to see more new patients, as well as perform additional surgeries. So there was a 12% increase in surgical volume, with slight increases in work RVUs due to an additional complexity of patients seen. So one final example around care team optimization here. This is a hospitalist team. We continue to see growth in the utilization of APPs in the inpatient setting, so especially hospitalists, intensivists, and on-cardiology teams. So we are frequently finding, however, that the role of the APP is not clearly defined. So in this case study, we show an organization that has had increased the number of APPs in the hospitalist team. However, their throughput indicators, such as time to discharge or time to admit from the ER, were not improving. And in fact, patient satisfaction was declining. So on top of that, they were experiencing an increased turnover of hospitalist APPs. And what they had found through exit interviews was that the reason was primarily due to underutilization. So our data shows, and what we were able to share with them, is that APPs who perceive they are underutilized are twice as likely to consider leaving. So that became a real factor for this organization. So through intentional conversation and design, they made some changes. So all admissions would be done by a physician or a physician and APP team. Subsequent inpatient visits would be completed by an APP. Inpatient consults would be primarily APP, but they determined that APPs could do consults for certain populations. They developed a new role for a hospitalist APP in the ER. So they would support writing admission orders and rounding and discharging inpatients as time allowed. So that new role resulted in earlier discharge times, shorter time to admit ER patients, and increased satisfaction. So as organizations work to establish care team models or work through an intentional process to define them, we sometimes see existing compensation programs get in the way. So I'm going to hand this over to Zach so he can lead us through the next section focused on compensation programs that will support optimized care teams.
Well, thank you, Amy. Now let's discuss some of those trends and strategies that's in compensation that support the care team optimization. As we begin to break down compensation, we think about team-based components of compensation, and we often find that there's some different degrees of team-based compensation. Historically, we have compensation programs that can create an environment of competition between team members, specifically as it relates to work RVUs. This is particularly common in primary care and urgent care, where APPs and physicians may feel in competition for the same patients or even the same work RVUs. While these models can promote individual productivity, they are often not aligned with things like value-based metrics or panel management. Additionally, sometimes the individual productivity has the effect of creating inefficiency within the care team, leading to overall less work RVU collectively compared with combined productivity of more cooperative models. As with care teams, there's a spectrum of team-based compensation models. We are now seeing the continued evolution towards the supportive and integrated models of care team-based compensation. It is not typically a quick transition for organizations, as the culture shift towards supporting or integrated models require a change in mindset away from individual contributor mentality and more to the results about team. Personally performed and individual contribution still matters, but in the context of the output of the team. In supportive models, there's a start of aligning of APP and physician productivity. This is typically through non-productivity incentives, value or quality-based, and this may include APP productivity thresholds to be able to start to receive those non-productivity incentives. We are seeing organizations consider more integrated models. These are truly aligned compensation models where the incentive plan for APPs and physicians is shared based on shared metrics and requires both physicians and APPs to meet those thresholds to receive payouts. This is truly a paying the team on the performance of the team while still recognizing the individual contribution of its members. It is important to note that in each of these models, the amount of incentive the physician would be eligible to receive and that the APP would be eligible to receive would be different based on market benchmarks and salary differences between physicians and advanced practice providers. Physicians and APPs have traditionally been rewarded very differently, with physician compensation focused predominantly on a model with a draw plus variable compensation that's usually based on productivity, with some kind of value-based metric achievement, typically. APP rewards aren't vastly different in terms of the components. They just tend to be more focused on guaranteed compensation that's tied with salary, with a potential smaller portion of compensation tied to incentive. So it's really about what buckets are being more utilized. Up to this point, there's been, APPs have been more risk-adverse workforce compared with physicians related to compensation. Physician compensation has been more variable and predominantly tied to productivity. Thinking broadly across the specialty spectrum, we see that the weightings of the type of rewards being offered is based on often how patient care is being delivered. For example, primary care specialties are moving faster to align compensation with population health strategies and value-based compensation metrics. Whereas at the other end of the continuum, we see coverage-based specialties, say hospital medicine or critical care, compensating predominantly on shifts or hour expectations with less compensation tied to productivity. Again, we talked about these team-based elements being considered more often in the past. And so thinking about in either primary care or coverage models, seeing as APPs manage more of their own patients, seeing some cooperative models in terms of team-based metrics. For the medical, surgical specialties, we tend to see more integrated model of physicians and APPs working collaboratively to provide patient care to a patient population. It's important then to create reward programs that support collaboration and eliminate barriers and competition. Let's get into some of the data. As APP compensation has seen big increases across all specialties from 2017 to 2019, with the biggest increase in medical and hospital-based specialties. Like with physician, APP compensation continues to differentiate between specialty categories, really coalescing around 4 specialty roll-ups. In this table, total cash compensation includes incentive dollars in addition to base pay, but excludes things like shift differentials or other premium pay. The data shown in this graph is by NP and PA combined, as we are seeing the combined salary model in over 80% of the organizations. Our 2020 market data was recently released, and we are seeing a similar upward trend as in previous years. Keeping in mind that our 2020 survey really represents 2019 data before COVID. We are continuing to analyze the results from the 2020 survey to better understand its meaning in the context of COVID-19. Now let's look at compensation of anesthesia providers and midwives. Just like last year, there continues to be pent-up demand for CRNAs as a result of several forces, including shortages of anesthesiologists and the completion of the conversion of CRNA programs to a DNP. New in 2019, we had data on anesthesiology assistants. This workforce has been around since the 1960s, but their ranks have really significantly grown in the last 5 years as a result of the shortages in anesthesiology. AAs, or anesthesia assistants, work with anesthesiologists in an anesthesia care team model to implement anesthesia care plans and are paid at rates similar to and practice very similar to CRNA as opposed to NPs and PAs. Certified nurse midwife compensation has increased more similar to the medical and surgical-based NPs and PAs. What about incentives? Median incentive payouts are shown for APPs on the left side of this graphic. Primary care APPs continue to have the highest reported incentive payout amounts of any APP type or specialty, expressed as both a dollar amount and as a percentage of salary. The dollar amount is increased $1,000 from the previous survey. These findings are even more telling when you take into account that, as discussed earlier, primary care APPs have the lowest overall total cash compensation rates as APPs compared to medical, surgical, or hospital-based specialties. Overall, we tend to see the incentive numbers ranging in the $3,000 to $7,000 range. It will be interesting to see how these numbers are impacted as more organizations consider or implement APP incentive plans and are starting to align them in team-based incentives, especially in the face of COVID-19. One last benefit or compensation element to speak about APPs is related to education and licensure benefits. This is an important topic for many APPs, and we'll discuss that in a second. But the median CME allowance and median days have both remained stable over the last several years. For APPs, the CME stipends continue to represent a significant issue. In our experience, its impact outweighs the dollar spend. For example, adding a $2,000 CME fund typically has a much greater impact than simply adding another $2,000 to base compensation. From a financial standpoint, the math is the same, but there's a non-quantifiable emotional lift that many APPs feel when they're treated more like a provider than a staff, and that's really what those CME dollars can represent. An area we get asked a lot about is regarding certification and licensure reimbursement. While 2/3 of the organizations report a separate reimbursement or certification license amount separate from CME, in our experience, most organizations look at CME allowance and licensure reimbursement holistically. Even if they have separate dollar amounts, they'll look at the $2 together. Now let's get into a couple case presentations. Our first example is a primary care example. This organization is a multi-hospital health system with a large medical group comprised of a growing number of APPs. Historically, most of their physician compensation plans are on a typical work RVU model. A few years ago, they moved all the primary care physicians to a salaried model. Unfortunately, there were many unintended consequences of this plan and the inability to adjust some of their organizational management structures to the new model. The current state grew out of a salaried model without the proper management oversight or ability to hold providers accountable, resulting in decreased productivity, decrease in access, and overall a decrease in market share. Physicians were growing dissatisfied with the model as patients voiced concerns about their inability to get access, and the organization lacked the resources to support their practices with the shrinking market share. This carried down to the APPs, who had little expectations put upon them, and the roles varied and were typically not provider focused. Many of the APPs in this model worked as scribes. As a result, you really had dissatisfaction all around. You had growing dissatisfaction with the feeling like they had to continue to carry more patients while seeing decreasing resources, dissatisfaction with the APPs for the roles that they were put in, and dissatisfaction from administration as many of the metrics that they were counting on were lagging, including things like patient access and patient wait times. All in all, this new compensation model was not supporting the organization's goal to increase primary care. So how is the new model structured? As you can see, the overall base salary structure for physicians was maintained as the primary compensation element, with the addition of specific minimum work standards related to individual performance, productivity, and patient experience. There was also a team expectation around panel size as part of the minimum expectation. This gave the management team clear expectations to be able to hold providers accountable. Additionally, incentive compensation was introduced with significant nod to team-based metrics. Here you see patient experience at the practice level, panel size at the practice level, and then quality again at the practice level. This solution allowed for the organization to continue to provide the security of a base salary to physicians with the addition of clear work expectations for management, as well as the opportunity to include incentives that were really aligned with what the organization was seeking to do, grow the patient panel size and the footprint. Including these team-based incentives also set up the organization to be able to start to offer incentives for the APPs that were aligned with physicians. So this really gave the APPs a sense of being and an ability to be aligned with the physicians and the team so that everyone was really moving in the same direction. One final case example is an organization at the large regional specialty hospital and an employed medical group. This organization is focused on growing their APPs to help them provide a larger geographic area and to enhance the organization's financial performance. Like with many organizations, they had not adjusted compensation in many years. This was a real problem, especially for APPs, where organizations can find themselves quickly 7 to 8% behind market if they just look at APP compensation on a 2-year cycle. Like with many organizations we see, there was little to no alignment between the physician and APP compensation plans, and the results included competition for work RVUs, and there was growing dissatisfaction with physicians and APPs. So the organization underwent a care model redesign to look at several specialties and align their activities to optimize APPs to the top of their license, training, and education. But also they did something else. They also utilized other care members to the top of their ability and training, thus enhancing overall financial performance. And these are the things that helped improved access and throughput. Their greater utilization of all team members, APPs included, aligned with the organization to expand patient access. For example, by allowing APPs to see return patients more autonomously, this allowed the physicians to staff outreach clinics off-site and open up new service areas. As a result, the organization needed to look at compensation and designed a compensation plan that was aligned for both physician and APP. Both programs were market-based with plans for annual reviews, moving away from the 2-year cycle. Additionally, there are 4 different structures of plans based on specialty, performance, productivity opportunity to be responsive to the local market needs of individual practices. An important element was the minimum work standards that were developed for both physicians and APPs that included patient-facing hours, chart setting requirements, and extended hour coverage to really enhance that access. From an incentive standpoint, there was one plan developed for all providers, physician and APP, that was 5% of base salary opportunity, 2% tied to the medical group performance, and 3% that were metrics picked by the division. And the idea was to start to increase the amount of this incentive in subsequent years as their value-based contracts expanded. So how did this model out? On the left side is the physician compensation. On the right is the APP compensation. The physician compensation was still considered productivity beyond a fixed base, in this case about 64% of TCC. But as you can see, both the physician and the APP were eligible for the same medical group specialty incentives, in this case, time to third appointment and ensuring colonoscopy screenings. The model really focused on team alignment of care, allowing physicians and APPs to be able to generate work RVU without fear of competition, while APPs were included in the overall organizational performance and incentives. In the last couple of minutes here, let's talk briefly about the impact of APP leadership structures on APP engagement. So in thinking about things like decreasing turnover, increasing APP satisfaction, and engagement, we are seeing leading organizations leading employers of APPs use more intentional strategies to improve that retention. So thinking about our care model and having it being a very data-driven, intentional process, we're seeing the same thing about the recruitment and retention of APPs. So thinking about ensuring APPs have a voice within the organization, building structures that, and leadership that supports the optimal APP practice, and intentionally assessing current culture to ensure that it is aligned with APP practice. That's sending, for example, sending the right message to patients, families, and referring providers. For example, are APPs visible on the website? thinking about how staff introduce appointments with APPs as opposed to physicians, and whether physicians are familiar with and understand the rules and regulations. One big element of this is one important element of this is the APP leadership role. Our data suggests that APP leaders are really differentiated into 3 different groups. You have the clinical level leaders, which are responsible for clinical oversight, the unit or practice level. These are really operational people, primarily providing clinical care. You have your middle level leaders, which represent really 2 different types. You have APP leaders who manage other APPs, and you have others who manage specific processes such as onboarding, education, or student placement. Finally, you have the top APP leader, which you see in 93% of organizations, who spend almost all their time working on management, strategy, and administrative oversight of the advanced practice providers. You can see each of these roles are going to have different levels and different spans of control, and correspondingly different assigned FTE and compensation. But what's the value of these leadership structures? What's the return on investment? Our data suggests that the presence of an APP leader can reduce turnover by as much as 2%. This research, as Amy noted earlier, the research done by Sullivan and Cotter in 2019 identified that the direct cost of turnover for APPs ranges anywhere from $85,000 to $120,000 per year, not accounting for indirect costs such as patient wait times, decreased morale, and decreased efficiency. So you can see a 2% change on a workforce of 600 could have a significant cost savings. Other benefits include an anecdotal increase in APP productivity. We are performing analysis of our 2020 survey data to objectively quantify that impact that the APP leader has on APP productivity. We're also seeing a savings in terms of efficiency of processes such as onboarding, which are often fragmented and inconsistent, and could be standardized to be more efficient under an APP leader so that you have a decreasing time to full patient load. Additionally, with all the changing rules and regulations, it's often helpful to have somebody in the organization who's in tune with the regulatory, compliance, and payer landscape to ensure that not only your organization is compliant, but also that it's not continuing to administer supervisory or administrative practices that are no longer needed. So as we review what we've covered today, we ask you to reflect on some of the APP trends that most impact your organization. As we know, demand will only continues to grow for these professionals, and the COVID-19 crisis has only escalated the need to ensure that care models are efficient and patient-centric. Optimizing your APP workforce can have an important aspect in this end. APP workforce strategies should be tailored to support clinical workforce optimization and overall organizational strategy. We know that the role and value of APPs will continue to evolve as competition and demand increases due to industry pressures for more efficient care delivery. We have seen leading organizations that are leveraging APP roles to optimize clinical care teams and positively transform care delivery. We have witnessed alignment of APP and physician reward strategies as an important consideration and is leading to shifts in physician and APP incentive compensation design. We believe the growing overall prevalence and scope of responsibility, APP leadership roles and structures are the cornerstone of effective APP utilization and can represent significant cost savings. In summary, a comprehensive APP workforce strategy, including total rewards, should be customized to the unique needs of the organization and can have significant impact on meeting the organization's financial goals and overall strategy. Amy and I would like to thank you for listening to us today, and we'd be happy to answer a few questions.
All right, well, thank you, Amy and Zach, for that information. There has been a very lively conversation in the chat so far. I know we won't get around to everything. I want to quickly highlight a few questions that may not have gotten to during the session itself. Catherine had asked, can the impact of split or shared billing be discussed?
Sure, this is Zachary. I think I did get to it at the end there, but we still see that as a fairly common practice in our experience. I think that the biggest considerations are making sure to know which settings that it's appropriate and where it's not allowed. In our experience, the split shared visits tend to work best in the inpatient settings as opposed to the hospital ambulatory clinics, where we can find that it can often decrease clinic throughput and efficiency.
Excellent. I know we also had a lot of questions about how many types of APPs and different care settings can they operate fairly independently. But I think a bigger question is those areas where you have to build incident to for those APPs. A lot of people asking, what are the best practices or resources that you can recommend for billing incident to for your APPs?
This is Zach again. What we've seen is organizations really starting to move away from incident to for a couple of reasons. One is there's inherent inefficiency often in that model in an ambulatory environment in terms of making sure that you are complying with all the regulatory requirements around incident to. The other thing is that MedPAC this year had made recommendations to Congress to remove incident to, and so those we have waiting to see if that's going to get picked up or not. But it may be that incident to will be phased out here in the short term. And so we're still waiting to see that. Again, from a clinic flow standpoint, it often doesn't make sense to have the incident to, as what ends up doing is it ends up slowing the clinic throughput.
That's a great point. And Dorothea alluded to this in the chat as well, that CMS may do away with incident to billing at some point. Of course, our MGMA government affairs team is always watching for these developments. And if you guys have any questions about the regulatory aspects of that, definitely reach out to our government affairs team in Washington, D.C. They're always just a phone call or email away. Their email address is govaff@mgma.org. They're always available to answer questions relating to the regulatory aspects. Of course, CMS's guidance on incident to is just one of those that, of course, a lot of commercial payers have followed along ever since it was introduced. I want to see if we can squeeze one more question in here. Someone asked, how do I convince the legal department of a large hospital organization to pay physicians based on the care team model rather than only personally perform procedures?
Yeah, I'm happy to take this one as well. We're seeing a real kind of starting to see a shift in the market in terms of organizations looking at their comp plans. And so part of it is thinking through what is your compensation structure and making sure that the APP and physician compensation plans are aligned. But it usually is less about saying, let's pay them for this individual work, as opposed to looking at the whole work that's being performed, that needs to be performed, and then thinking about how physicians and APPs are best aligned to do that, and then making sure that those compensation structures are aligned so that they're cooperative and that they're rewarding the team, not necessarily individuals that are in competition. And so, again, happy to have further discussion with the individual that asked that, but we are seeing a look at the physician compensation plan more holistically as organizations start to figure out how to align all the care team members to a common goal.
Well, thank you, Zach, for that. I just want to put one more reminder in the chat. Obviously, so many great questions, a lot of nuance to using APPs. You can, if you want to continue this conversation with your fellow attendees or schedule time to speak to our speakers, go to the meeting lobby in Hub. It's on the left-hand tab that says schedule meeting. You can find multiple ways to keep these conversations going. And thank you all for the great, robust conversation today. That will conclude this session. Thank you so much for joining us and have a great rest of your conference day.